Good day and welcome to the Chronic Graft versus Host Disease and How It Affects the Lungs conference call. Today's conference is being recorded. And now at this time, I would like to turn the conference over to Jennifer Gillette. Please go ahead, ma'am.
Thank you so much, Jake. Yes, my name is Jennifer Gillette, and I'm the staff social worker at the National Bone Marrow Transplant LINK. I'd like to welcome you to our Lunch and Learn with the LINK today. This month's program will focus on chronic graft versus host disease and how it affects the lungs. A special thank you to our sponsors for today's program, the Leukemia and Lymphoma Society, Insight Corporation, Pharmacyclics and Janssen, and the Omeris Corporation. We also thank our esteemed LINK partners. Just so everyone knows how the outline for our program will go today, first, I'm just going to tell you a couple quick things about the LINK for those of you who are not familiar with the National Bone Marrow Transplant LINK. Second, we'll have Dr. Carrie Kitko speak to us about Lung Ghd, and she joins us from Vanderbilt University Medical Center, as well as we will have a survivor speaker, Whitney Davis, who had MDS, and also has dealt with graft versus host disease of the lung. And then we will have about half the call for questions. So for those of you who may not be familiar with the LINK, our mission is dedicated to helping individuals and their families from diagnosis through survivorship. We provide resources, support, and education. Some of the resources we provide to help families navigate this journey are our webinars and podcasts, our blogs, our lunch and learn calls like the one you're on today, and we have a variety of topics such as chronic graft versus host disease, disease-specific information, caregiving, coping, treatment options, and survivorship after a transplant. We also have a very content-packed Facebook page with daily inspiration, relevant tips for survivors, and we have our peer support mentor program for patients, caregivers, and donors. We also have our second birthdays recognition program, as well as a wonderful series of books, and we provide emotional support and referrals. So if anyone needs extra support on their journey, please reach out to us and let us know. Before we begin today's program, I would like to review just a couple quick housekeeping items to maximize the experience for all on the call. First of all, please be mindful in being as concise as possible with your questions so that we may answer as many as possible today. Also, please know that the information provided in this program is meant to stimulate conversation with your own healthcare provider and is not meant to replace your individualized medical plan. So now on to the remainder of our program. We're so thankful to have our first speaker here with us, Dr. Carrie Kitko. Dr. Kitko joined the Vanderbilt Pediatric Hematology Oncology Program as the medical director of the Pediatric stem cell transplant in June 2015. She had previously worked at the University of Michigan, initially as a clinical fellow in 2003, and then was appointed to a lecturer position in 2006 and promoted to assistant professor in 2009. During her time at Michigan, she developed a clinical and translational research focus in graft versus host disease. She has concentrated her research focus on GVHD diagnosis, treatment, and prevention. She is currently serving as a co-chair of the Gvhd Working Committee of the Center for International Blood and Marrow Transplant Research. She has been serving as a chair of the Gvhd Strategy Group for the Pediatric Transplantation and Cellular Therapy Consortium. At Vanderbilt, Dr. Kitko serves as the lead investigator for the Mount Sinai Acute Gvhd International Consortium. This consortium has furthered Gvhd biomarker discovery and has brought innovative clinical trials to our patients that allow for biomarker-directed Gvhd prevention and treatment. Recently, Dr. Kitko led Working Group 2A of the NIH Consensus Development Project on criteria for clinical trials in chronic graft versus host disease. The 2020 Clinical Implementation and Early Diagnosis Working Group report that was published in the Journal for Transplantation and Cellular Therapy last year. So in other words, we have brought you someone who knows GVHD well to speak to you today on this topic. Thank you so much for joining us today, Dr. Kitko.
Well, thank you very much for the invitation. I'm really pleased to be able to talk to this group today. Hopefully provide some sort of background information, where things are at present with lung GVHD, and maybe even some insight into where things might be going in the future. So with that, I'll just get started. So I just wanted to briefly touch on, like, how do we know if a patient has acute GVHD versus chronic GVHD? So as many of you know, because you've all been through this before, acute GVHD is the type of graft versus host disease that we see early after the transplant, and usually only affects the skin, the liver, and the gut. Whereas chronic GVHD happens later post-transplant and can affect virtually every organ in the body, and the lungs are one of those target spots. We used to say that everything that happened before day 100 was acute and everything that happened after day 100 was chronic. But that's really not the case. And as we've recognized, the disease really does look different. And so you should diagnose, is it acute or is it chronic, based on the symptoms that you see in front of you, and not necessarily what day the patient is after their transplant. So, with that in mind, how do we figure out that somebody has lung GVHD specifically? It can be very challenging as one of the physicians taking care of these patients, because, our patients tend to have a lot of pulmonary symptoms. Those are very common after transplant. Our patients are also prone to infections, often respiratory illnesses, that can also complicate matters as well. One of the things that was helpful is that these NIH consensus projects have really helped define, very strict criteria to help us sort out when patients have chronic GVHD. This is helpful so that when I'm talking about a patient with chronic GVHD, it means the same thing if the patient's at Stanford, or if the patient is in Boston or at the University of Michigan, that we're all sort of using the same language and the same criteria to make that diagnosis. On the flip side, it's because it is quite strict, it's hard to sometimes really meet these exact definitions. And what do I mean by that? So to make the diagnosis of lung GVHD, we look typically at our patient's pulmonary function test. So if you remember, you all probably had to have those PFTs done as you went into transplant, and you probably had several after transplant. And those tests show us how much air is moving into and out of the lungs. And when we look at the different values, when we get those reports back, it can help us figure out, are the patient's lungs healthy or are they not healthy? And if they're not healthy, in what way are they not healthy? So the strictest definition of lung GVHD, it's an obstructive defect. So that immune system has turned itself on and unfortunately is attacking the small airways of the lungs. So, and it's specifically the small bronchioles, but not the very ends of the airways, which are the alveoli. So you get this sort of stricture, if you will, around that small airway so that the air can get all the way to the alveoli, but it's hard for the air to get back out. So that's what we call an obstructive defect. And when I'm looking at somebody's pulmonary function test, if you're looking at your report, that's the FEV1, or the forced expiratory volume in the first second. So we look for declines in the FEV1 more than the FVC, or the forced vital capacity. Changes in the forced vital capacity tend to be more of a restrictive nature. And again, one of the challenges of making the diagnosis is that our patients often have a mixed picture. They don't have a purely obstructive defect or a purely restrictive defect. They're usually somewhere in the middle, which can make it sometimes hard to feel 100% confident just looking at pulmonary function studies to be able to classify the type of lung problem that the patients have. So then we also look to other ways of assessing the lungs, and the best additional test to get is a CT scan of the lungs, where we actually get images when a patient is taking a big deep breath in, and then they get images again of the lungs as they've taken a full exhalation. And so we try to blow out as much air as possible. And when you compare those two pictures of the lungs that we've gotten with the CT scan, you can actually see areas of what we call air trapping on the CT scan, which can help support that diagnosis of lung GVHD. There are also associated findings like bronchiectasis, or sort of larger airways than would be anticipated. So that can also be seen on the CT scan and can help with sort of nailing down that, yes, I really do think my patient is suffering from lung GVHD. And finally, for me, one of the most challenging things that's in these NIH consensus criteria to make the diagnosis is that the patient cannot actively have an infection. And that makes good sense. If you recovered from a cold, for the first several weeks after you've had a cold, you might be coughing more, you might be more short of breath. But the further out you get from that cold, that you start feeling better, you're breathing more easily again. And so you don't want to confuse just a post-infectious issue with something like lung GVHD, where you're going to be adding on new treatments. But again, in our patients after transplant, it can be very challenging because they can get recurrent infections, so it's hard to get that window where they're not actually fighting an infection. As well as we know that there's data that sometimes a viral infection or any type of infection actually might be a trigger for the development of the lung GVHD. It's like the immune system went to help fight the infection, but then it got turned on and looked at the lungs and decided that they looked foreign or different and then started their attack. So that no evidence of infection for me can sometimes be a real challenge to then tease out if the patient has lung GVHD or just consequences of having frequent infections. So let's say that I have the perfect patient and they meet the perfect diagnostic criteria. Well, what can I do then to try and treat their GVHD? Well, treatment for lung GVHD is, based on what other symptoms the patient is having. So if it's not just the lungs, but other sites of disease as well, like the eyes or the mouth or skin rashes, as just some examples, then the patients are probably going to be on steroids. Steroids are still, after several decades, our frontline treatment for GVHD. But steroids, as I'm sure this audience knows, have a lot of side effects that are unpleasant, and we do like to try and find sort of the minimum dose of steroids to help keep the symptoms under control. And again, one of the questions I know that had been posed is, are the changes reversible that happen to the lungs? And unfortunately, most of these changes that we see, we think of as scarring. And so we're trying to prevent further progression, but we have a hard time with most of our known therapies of actually reversing that scar tissue once it's formed. So that is also a real challenge for us. We do have some evidence of some less toxic therapies than steroids. So FAM therapy, some of you might be familiar with. So FAM is a triple combination of fluticasone, which is an inhaled steroid. So sort of the equivalent, if you've had your skin rashes from GVHD, putting on a topical steroid cream directly on the skin. Fluticasone is that same idea, but directed toward the lungs. And then 3 times a week, azithromycin. So it's an antibiotic, but on that schedule of Monday, Wednesday, Friday, it actually has some anti-inflammatory properties that we think are quite helpful for the lungs. And then montelukast is the last one. And so that's a medicine that targets macrophages, which we also think are important for how that fibrosis is developing in the lungs. So that triple therapy with FAM definitely has helped many people. There was a study out of the NIH that had shown that it definitely did seem to help stabilize many patients' lung function decline, so that FEV1 stopped decreasing in many patients. And so that's real, and it's generally speaking, a very well-tolerated therapy. So I think most of us, if we're worried our patient is developing some lung GVHD or early declines in their pulmonary function studies, have a pretty low threshold for starting FAM therapy. Now, I did mention that, our goal often with patients with lung GVHD is to sort of stop the progression of disease, but we have a difficult time reversing the disease. Some of the good news potentially is that we now have more tools in our toolkit. So there are now 3 FDA-approved agents for chronic GVHD, which we did not previously have. And so these target different areas of the immune system. And so they might work for one patient, but not the next patient. The first that was FDA approved several years ago, about 3 years ago now, was ibrutinib, and this targets B cells, which we think are more active in chronic GVHD than acute GVHD. Personally, I have not seen a lot of patients have massive improvement if they have lung GVHD with ibrutinib, but it's certainly possible, and it could be worth a try. Ruxolitinib has been more recently FDA approved. This medicine kind of focuses on some of the cytokines or the proteins that are revving up those immune cells. And so by sort of taking the foot off the gas, if you will, then hopefully the immune system sort of downregulates itself and is not quite as inflammatory. Again, there were some patients on the initial study that did have lung GVHD and did see some improvement in a few of the patients that had lung disease on that study. But I think the most promising agent that we have available to us right now is a medicine called belumosudil. And so this is a medicine that targets a protein called ROCK2. And it probably doesn't matter what ROCK stands for, but what is important is it works by 2 different mechanisms. So one mechanism that it works on is trying to sort of reset the balance of some of those immune cells. So the T cells we still think are, T and B cells are both important for chronic graft-versus-host disease. But in particular, what we see in our chronic GVHD patients is that the T cell ratio of the T cells that are revved up and are attacking the body are enhanced compared to what we call the regulatory T cells, or I kind of think of them as the police officer cell, if you will. They sort of go and find those ones that are revved up and say, cool it, you don't need to be so active. And so what this medicine, belumosudil, does is it kind of flips that ratio. So it turns off those reactive cells and helps improve the number of those regulatory T cells. But I think the coolest thing about this new drug is that it's actually involved directly in the fibrotic pathway. So we, for the first time, might have an agent that actually does have some ability to potentially reverse some of that fibrosis that we see in our patients. So for me, that's a really exciting development and potentially a way forward for our patients that we might have a new agent. Other things I think are important to focus on are supportive care, which for our patients can be every bit as important as the actual immune suppression that they're on. So our patients with lung GVHD obviously, can struggle on a day-to-day basis with feeling short of breath and having a hard time doing their normal activities. But I think equally important and problematic for our patients is the increased risk of infection, because if they get another pulmonary infection, we can often see further decline in their pulmonary function. So really trying to make sure that we've optimized their antimicrobial prophylaxis strategy. So making sure that they're on the right drugs to help prevent like mold infections, making sure they're on the right medicines to prevent particular bacterial infections, and making sure as best as we can that their vaccines are up to date. Now that is sometimes a bit of a double-edged sword, because if you're on immune suppression to treat your GVHD, you might not be able to respond to your vaccines as well as we would like. So it's, sort of a balance, but I certainly recommend that my patients get their as many vaccines as they can and test their response and give extra boosters if we have to. And this would include making sure that my patients get the COVID vaccine as well. I think another piece is making sure that our patients are plugged into physical therapy, sometimes even pulmonary rehab. I think trying to sort of let the body, almost like reset the thermostat, if you will. If you've had some lung damage, there's ways of improving your stamina to be able to accommodate for the fact that your lungs might not be as healthy after your transplant as they were before the transplant. And then I think I will just end with a few minutes on some of the future directions, things that I know that we're working on. So we definitely would love to be able to diagnose lung GVHD earlier, and to be able to have reliable signs or symptoms that we know, okay, the patient isn't very symptomatic yet, or hopefully isn't even having any symptoms, but there's these subtle signs that I can point to and say, I know this person is at high risk and potentially intervene. There are natural history, what we call natural history studies ongoing at several places where they are following the patients really, we're getting them before the transplant and following them very frequent through the first year to try and see if we can figure out what some of those early indicators might be. Some of this involves more frequent pulmonary function tests, even something called a handheld spirometer. So it's like a piece of equipment that the patient can be doing at home with measuring that forced expiratory volume at 1 second so that we can potentially catch some of those changes early. The sort of downstream effect is even if I find that early sign, what could I do as my intervention? What drug would you want to expose your patient to that isn't too toxic, but also could potentially have benefit? FAM therapy might be an option, starting that earlier as patients are starting to show declines in their FEV1. But maybe there's another medicine out there that we could think about. Somebody also asked about biomarkers. Biomarkers are great. I will say they are much further ahead in our research efforts and even clinical trial design incorporating biomarkers in our acute GVHD treatment trials. Chronic GVHD by its nature it involves more organs. It can look very different from patient to patient. So we are finding biomarkers. They have not reached the same significance where I can use them yet to direct my patient's therapy. But again, we've incorporated frequent blood draws into these natural history studies, and my hope is that 2 or 3 years from now, if we have this talk again, I can be talking about advances in chronic GVHD biomarkers that we are now able to use to help guide our patients' treatment. And then finally, one more agent that is not yet FDA approved, but there are clinical trials ongoing, is a medicine called Exatilumab. So this is a medicine that actually blocks very specific macrophages. And it's often the macrophages, that's a type of white blood cell that they're in our tissue. They sort of go from the bloodstream and migrate into the various tissues. And once they're there, they are often the driver of promoting the fibrotic environment that we see in the lungs or in the skin, for example. And so we've had patients on this medicine, Exatilumab, and have seen improvements in both lung function and skin findings as well. So again, I think we're finally seeing some agents that rather than just slamming the immune system and leaving our patients vulnerable to infections as a way of just essentially stopping the progression of disease, I feel like we're finally seeing some agents that might actually target what our patients care most about. Can you make me better? Can you actually improve my lung function? So I'm here today to say I'm more hopeful today that we might actually be making good progress in that area. And so that was what I had planned on chatting about for now.
Thank you so much, Dr. Kitko. I swear I learn something every day, and I just learned a lot from you. Thank you so much. And now we are going to hear from Whitney Davis, who is not only a survivor of MDS, but she also has lung GVHD. So she will share her story and experience, and hopefully you will learn a tip or two in coping with this. Thanks for joining us, Whitney.
Absolutely. Thank you for the invitation to be allowed to do this. So as she said, guys, my name is Whitney. I'm 34 years old. I had my transplant when I was 29 years old. I was diagnosed with a thing called myelodysplastic syndrome. It was very new to me. I had never heard about it, didn't really know what it entailed. That's when they explained to me that I would have to have a stem cell transplant because they said it wasn't if it turns into leukemia, it's when it turns into leukemia. I waited about 8 months until I was able to get my transplant. Everything with the transplant went fantastic. I was only in the hospital for roughly 20 days afterwards. I got to go home with my family, be with my daughter, and then I started having symptoms of acute graft versus host. I was originally diagnosed with it in my gut. Very soon after being diagnosed with my gut, it was in my sinuses. I started randomly having seizures that I'd never had before. They didn't know if it was from graft versus host or if it was a complication of the transplant. And then from my skin and my sinuses and my gut, it moved into my lungs, which I wasn't diagnosed with it until about a year later. I had hip surgery due to a complication from the steroids, causing my hips to collapse. And when I started coming out of my anesthesia, my oxygen wouldn't get above 80. So they put me into the hospital that night trying to get my oxygen up. They weren't sure what was going on. And I kind of told them, I was like, I'm used to it running about 89, 90. I wasn't really familiar that was low. So from that point, I stayed the night in the hospital, and then I was recommended to go do a PFT. So when I did the PFT, my FEV1 came back, I believe, in the 40s. They said that it looked like I had an obstruction. They weren't sure what was going on. And I actually got put on the combination of drugs that Dr. Kitko had talked about with the montelukast, the azithromycin, and the other one. I stayed on that for roughly about 6 months. I started getting really short of breath. I just started having a lot of complications with breathing. So they gave me albuterol and told me, to do the breathing treatments and to use the inhaler twice a day as needed. That helped me for just a little bit. Complication that apparently came from my surgery was I had blood clot in my legs. So I went to the hospital one night. My oxygen was in the 70s. I don't remember most of the night, but I do know that my oxygen stayed between 65 and 70 that night in the emergency room. At that point, they decided to do a chest CT, and they said that it looked like I had ground glass granules in my lungs. So they kept thinking that I had COVID. I spent 2 weeks on a ventilator, and after that, they proceeded to do 13 COVID tests on me, thinking that it was just coming back negative. My lung function when I was in the hospital dropped down to 15%, and they were still trying to go with the diagnosis of COVID. They really didn't want to go with the graft versus host of the lungs. They wanted to do more tests since there had been a recent infection, as Dr. Kitko was speaking about. So I spent 45 days into the hospital. My lung function, my lung O2 stats had finally got to where they were saying between 90 and 92. They finally let me go home. When I went home, I was on oxygen 24/7. Basically, the only time I came off of it was to take a shower and get ready for my day. So at this point, we did another PFT, and my FEV1 had dropped down to around 30. So at that point, we went and did another CT of the lungs. It did still have the ground glass granulates in there. They were like, maybe you have an infection. Let's test for one. I went through, I did sputum cultures. I did another CT. So all in all, I had 4 CTs that all came back looking the same. They were like, let's just wait just a little bit longer before we diagnose you with the lung graft versus host. So I went back and did one more PFT, and that's when they officially said, we're going to have to call it. It is what it is. You have the graft versus host of your lungs. At this point, I was taken off work full-time. I was still on oxygen full-time, and life just got to the point to where it was just really unbearable. I was recommended to actually see Dr. Kitko from my oncologist in Memphis, and going to her was fantastic. She recommended that I try the belimosadil, And after trying the belamostadil, my experience with it has been I lost about 50 pounds of fluid that was on me. My skin has returned back to normal. I'm no longer on oxygen, and I am back at work full time. So it has been excellent. Coping and going through this was something that was very, very hard for me. I have a young child and my husband. Those are my support system. My mother who lives by. But coping was very, very hard for me. I didn't know what to do. I didn't know how to explain to my daughter that I was only getting sicker. So some things that I did that helped me cope with this was I would write letters to what I was angry about. Dear lungs, today, I have felt like this. Today you have made me feel the lowest of lows. I hate you, just to get it out, because you can talk to people all day long, but if they don't understand what you go through, then sometimes the advice is just, it's appreciated, but it's kind of hard to take in. So like I say, coping for me, writing the letters to the part of it that I was very angry about. And then I just tried to surround myself with the most positive people that I could. If I had anyone in my life that was negative, it was one of those things that I had to move on from and just really make sure that I was always around someone positive. Going through and doing daily Bible verses and inspirations and joining groups of other people who are like us, who have the same complications that we're able to talk with and talk through. I have more friends on social media that have been through the exact same thing that I have than I have friends in real life. And it's just because it's easy to talk to them. It's easy to explain what's going on. When you're mad about it, they understand what you're going through. So just for me, like I said, talking about it was the biggest way that I was able to cope with it. So, and that kind of wraps up my journey with it.
Wow. Whitney, we can't thank you enough for your authenticity and just sharing. It's amazing what you've gone through and amazing where you are today. Thank you so much for sharing that. I'm sure you've provided some hope for others today. Jake, I think this is a good time for us to let our callers know how to ask some questions of these ladies.
Of course, ladies and gentlemen, if you would like to ask a question, please signal by pressing *1 on your telephone keypad. Just keep in mind if you are using your speakerphone, make sure the mute function is released so that signal can reach your equipment. And there will be a voice prompt on your phone line that indicates that you have an open line. Just state your name before posing your question. We'll hear first from...
Hi, my name is Ann Lemke, and I've been diagnosed with BOS, which is the lung GVHD of the alveoli that the doctor and Whitney were talking about. Diagnosed 7 years ago. I've been on clinical trials, KDO 25, and now I'm on a clinical trial, and Exatilumab, and I think the doctor had mentioned that. Ongoing, I have antiviral, antibacterial, antifungal, and I've been lucky. I've never actually been in the hospital with infection, so I'm lucky in that respect. I could not believe Whitney's story. Amazing. And so I want to follow up with the drug that I've never heard of, and the doctor had mentioned that, which is the Biomarkers as a ROX2 drug, and involving the fibrotic pathway. My last pulmonary function test was in February of 22, and my FEV1 is 35, so it's obviously not great, and it's been going down over the 7 years. Not a lot, but now it's into the 7 years. So my question, I'm sorry, is is that Balomexidol that has really helped Whitney? Is that something I should get? Because I know my doc will agree. He's the main guy at Dana-Farber.
So, I think it's definitely worth talking with your local physician about Balomexidol, and if that's an agent that would be a good fit for you. It tends to have a pretty good side effect profile. Some patients can be a little bit fatigued on it. Some have nausea and vomiting, although I feel like that's on every label out there for every drug. But fatigue, I think, is probably the most common thing that folks have commented on. So it's definitely worth considering if it's a drug that you haven't seen before. It's nice because it is a pill, and most patients only need to take it once a day. Some patients take it twice a day if they're on other medicines that can sometimes make the levels a bit lower. So from a convenience factor, that is also a nice benefit with the Balomexidol.
Balomexidol, and you think that's significantly better with your patients as opposed to the Exatilumab, the ones that they're doing clinical trials that I'm in. Yeah.
They have not ever been compared head to head. So it's really impossible to say if one is better than the other. And I will say from personal experience, it's really hard for me to know with any patient that I'm sitting in front of which drug is going to work for them. It's clear for some patients, these drugs almost feel like a home run. I mean, like Whitney tells such an amazing story about how well she did with that. I've had other patients that I've put on it and they've had some improvement, but maybe not quite the same home run. But then, another patient I had on the clinical trial with the Exatilumab, and that one did great. And then another patient that had the severe, skin thickening and lung declines didn't seem to benefit at all. So again, I think we're all hopeful that things improve in terms of our ability to look at things like the biomarkers that might actually tell us before we start certain drugs if a patient is more or less likely to respond to them. So I think it's hard to look at those drugs head to head and say that one is better than the other. For the reasons I just outlined.
Yeah, no, I understand. It's that would be predicting the future, and it's pretty tough to do. Yeah. Okay. Well, thank you very much.
You're welcome.
And once again, ladies and gentlemen, if you would like to ask a question, please signal by pressing *1 on your telephone keypad. We will pause for just a moment to see if there's any further questions today.
I have a question for Whitney. Whitney, I know you had shared that you yourself had gone through COVID. Could you tell our callers a little bit about that experience and how you got through that?
Absolutely. My daughter she had COVID one time, and through that round that she had COVID, I had to completely separate myself from her, which was the hardest thing in the world. Well, she came home from school again with a runny nose. Her throat was hurting her. She didn't feel good. We did a COVID test, and she popped positive for a second time. The next day, I wasn't feeling too well, so I took a COVID test, and that's when I came positive. And I immediately let my oncologist know what was going on. They put me on preventative. They put me on Pepcid AC or famotidine twice a day, and said, for me to take that and that it would help lessen the symptoms a little bit of the COVID. So the symptoms that I had, of course, were a lot of respiratory ones. I had tightness in my chest. It was hard for me to breathe. My oxygen around that time was staying in the 80s, and I was on oxygen full time at that point. And so for me, I stayed very exhausted. I stayed very tired, fatigued. I didn't want to get up. I didn't want to do anything. And I just took the preventative like my doctor had told me to. I had both shots and the booster. So they said that probably made my symptoms a little bit better. But really just trying to get the rest and making sure not to get up and overdo it. Like I'd have my husband, do everything for us that he could. So I wasn't exerting any extra energy and hurting my lungs even worse.
About how long did it take for you to kick it?
I tested positive for 8 days, and I felt just drained and exhausted for probably about 10 to 12 days.
Well, we appreciate you sharing that because I know there are a lot of people concerned these days. Any thoughts to share, Dr. Kitko, as you've seen patients with this facing COVID?
Yes, I think it's really important for our patients to get those COVID vaccines, including the extra boosters that we're recommending for our immunocompromised patients. I do think it has helped our patients that when they have unfortunately come across COVID themselves, have a better than predicted course. As early in the pandemic, I think we all heard about poor outcomes for many of our patients, unfortunately, that came across the infection. So I think we are hearing more stories of patients able to recover from COVID that get the vaccines. It's not 100%, but it's certainly giving our patients a much better chance.
Great, thank you. Jake, is there anyone on the call?
We did have several other questions enter the queue. We'll hear next from.
Hi, this is Deanne. Can you hear me?
You sure can. Hi, Deanne.
Okay. Hi. Thank you for the presentation to both our speakers. I have two questions. One, what is the opinion on Evusheld for a prophylactic for COVID?
So I am certainly recommending it to all of our patients that are either really early post-transplant or patients that have GVHD requiring immune suppression therapy, that they receive the Evusheld doses.
Okay, excellent. And then the second question, these two drugs you talked about, the Biomarkers and the Exatilumab, are those short-term or long-term drugs? For patients that have responded, then they have stayed on those medicines long-term. So, for example, the Exatilumab is on a clinical trial, is an IV infusion, and there have been patients that have been taking it now for up to 2 years. And Biomarkers, similarly, patients that are responding tend to stay on it for definitely months, even over a year for Biomarkers as well. I think the issue, again, is a lot of our patients have that scarring fibrosis, and that doesn't completely resolve overnight. So if patients are continuing to feel their skin softening, they're slowly feeling like their lung function is doing better, then they're often staying on those medicines to hopefully continue to get benefit. I will say that they both also seem to have what I call steroid-sparing effects, so that they're seeing some improvements, and so then we start trying to get them off their more toxic medications. So things like their steroids, things like mycophenolate, or MMF, other drugs like calcineurin inhibitors that can be like tacrolimus and cyclosporin that can be hard on the kidneys. So I think we've definitely been able to get patients maybe off some of their more toxic agents and continue to see, stable disease to continuing improvements in some of those more difficult to treat organs. Excellent. Thank you. That's it.
And now we'll move to our next caller.
Hello. Hi. My name is Kathleen. I'm from Portland, Oregon. And I have a quick question, Doctor. First of all, thank you so much. Will your notes or some sort of summary of this presentation be available that I could read so that I can recognize the spelling and know the names of all those medicines that you're mentioning. I'd like to share them with my pulmonologist. If he doesn't know, I'd like to be familiar with them.
You know what? I'm sorry. Go ahead, Dr. Kitko.
Oh, I was just going to ask. Yeah, I mean, I'm happy to share some notes that can be distributed. I just don't know the logistics on how that would work. So maybe Jennifer can let us know the logistics piece of that.
You know what? If you send me anything that you would like for the callers to have, I will be happy to pass that on, as well as I know there is a lot of details and a lot of great information shared here today. I'm happy to try to get the transcripts from today and send them out as well.
Thank you so much.
You are so very welcome.
We'll now move to our next caller. We'll hear from.
Hi, can you hear me?
Sure can.
Yes.
Okay, my name's Dorothy. I have two questions. One, you mentioned CellCept as being one of the toxic medications, and also I've read about autoantibody testing in, I guess, for COVID and also autoimmune diseases. And I was wondering if GVHD, if you have more autoantibodies in your blood that could be picked up in a test.
So the autoantibody question. So there definitely are some patients that we know we can find some of these antibodies. So probably the best studied example is when a male patient has received a transplant from a female donor. So those female immune cells haven't ever been exposed to the Y chromosome before, and they've actually been able to find anti-Y antibodies in those male recipients from a female donor. So there's other examples of that, of other antibodies that have been identified. It can vary, though, from patient to patient. So again, this gets to the challenge of some of our biomarker work, where it might be associated in one particular patient, but you might not find it in the next patient that you test, and they might look very similar when I'm doing my physical exam. But there definitely do seem to be these some role of antibodies in our patients, which is, I think, again, sort of speaking to what I mentioned earlier, we think it's both T cells and B cells playing a role in chronic graft versus host disease, which is very different than acute GVHD, which we really think is driven almost, entirely by those T cells.
Thank you.
Was there a question
about CellCept? How toxic is it long term?
It's the side effects of mycophenolate is that it can definitely cause a lot of GI symptoms. There's definitely patients that have sort of persistent nausea and vomiting while they're on it, decreased appetite. It can also cause bone marrow suppression, so people can have lower white blood cell and platelet counts while they're taking mycophenolate, and it's definitely causing some immune suppression. So we're trying to avoid infections at all costs if we can in our patients, and yet we're giving them medicines that are holding their immune system back in some way. So that's always sort of the challenge when we have patients on these medicines to treat their underlying disease, but yet you worry about infections as well. So, I think many patients can take CellCept on a daily basis and probably don't even necessarily notice some of those side effects. But I think that sort of ongoing risk of immune suppression is certainly a concern, even if they're otherwise tolerating the medicine well.
Thank you very much.
You're welcome.
And now we'll move to the next caller. We'll hear from.
Hello. My name is Tim. I'm 69. I was diagnosed with multiple myeloma in 2001, had my transplant in 2003. About a year later, I developed a nasty cold, and it moved into my lungs, and they've never been the same since. At any rate, now I'm on Symbicort and Spiriva every day, and albuterol is needed. My lungs are stable, but I have very short of breath. I'm fine if I'm walking on a flat surface. If I start up a hill, I get short of breath very quickly. At any rate, my question is, I've heard about Zephyr valves helping some patients with COPD. Is this an option for us?
Can you say that medicine again?
Zephyr valves, they're like a mechanical valve that's inserted into your lungs that helps the air escape that is trapped in there. And I've heard of several people having it done and with good success. I'm just curious if
yeah, it's a technology I have not seen used in our patient population with post-transplant lung disease. So I couldn't speak to whether or not it would work because I have not seen it used in our patients.
Okay. Apparently there's a couple different on the market. Zephyr valve, I know, is the one that I have a friend that has smoking-related COPD, and it helped him immensely. And I was just curious if it would be an option for us, but I don't know. Anyway, that's what I have.
Well, thank you for asking. Do we have
and once again, star one, if you have a question, we'll move to the next caller. Please go ahead.
I was just checking. I'm sorry, this is nbmtLINK again, and I was checking the spelling of the drug, and I think I do have it now, which is BELUMOSUDIL. Is that correct?
Yep, that is correct.
Okay. Thank you very much.
You're welcome.
And one final reminder, if you have a question, star one.
Well, we're waiting for people to ask more questions. I have a few from our pre-submitted. One, Dr. Kitko, does air purifiers or humidifiers help at all with people with lung GVHD or inhalations of salt water, anything like that? Would that be helpful for people?
So again, we worry a lot about infections for our patients, and so things like HEPA filtration could certainly potentially be helpful for patients, but that's a big investment for families. I do worry a little bit about humidifiers because they can often be, if they're not kept super clean, they can be sort of a breeding ground for molds and things. And again, when our patients get mold down into their lungs, that can be pretty damaging. So we worry a little bit about humidifiers. In terms of saltwater nebulizers, I think good pulmonary care is important, and if patients are having a lot of wheezing, a lot of recurrent infections, then some of those types of treatments that can help them mobilize some of their secretions would be helpful, but not everybody with lung GVHD necessarily has those types of symptoms. So I wouldn't say every patient would benefit from that, but I'm sure there are some that would.
Great, thank you. Do we have any other questions at this time, Jake?
We do. A couple entered the queue. We'll now hear from.
Hi, this is Sandra. I'm here with my husband, Mike, who is the patient. My question is about long COVID. How many patients have you had who have been diagnosed with long COVID, and what are your recommendations? Mike had COVID at the beginning of the pandemic, spent 11 days in ICU, 3 on a ventilator. He's okay, but he has super fatigue. He really has a hard time getting around at all. He has physical therapy here at home several days a week, and he's making lots of progress in terms of strength, but not stamina. Is that typical with long COVID?
I think long COVID can look different for different people, but certainly the fatigue issue is real and something that many patients have struggled with. Does your husband also have GVHD on top of the long COVID?
Yes. He's been hospitalized 30 times in 6 years. not always for lung issues, but always GVHD related.
Got it. So, some of again, it's not every patient, but there are definitely some patients with just GVHD, even taking COVID out of the equation, that can struggle with fatigue as well. And so, some patients will even explore things like needing to take stimulants, like patients with ADHD, to try and help stay awake and be more active. I don't know if that would be the right thing for your husband, but again, if he continues to struggle with this, that might be something worth at least discussing with your physicians. Many hospitals are now establishing long COVID programs, and that might be something also to consider exploring as well.
Thank you.
Now moving to our next caller, we'll hear from.
Hi, this is Kathy, and I'm calling from Canada. And I've got a couple questions. I'm just wondering, have you ever heard of, or do you recommend or not recommend L-cysteine for lung GVHD?
L-cysteine. So I am not familiar with using that for graft versus host disease. So that's not an agent that I have used routinely, so I guess I can't, unfortunately, comment very much on that.
Okay. And now we're allowed to get a fifth vaccine. If we've had 4 vaccines, we're now allowed to get a fifth COVID vaccine. Do you believe that it will be helpful, effective?
I do think it will. I think, they have started to, so the Bone Marrow Transplant Clinical Trials Network has done a study looking at vaccine responses in patients post-transplant. And it does seem like it takes 2 to 3 doses before we see our patients really increasing their antibody levels. And there's definitely some concern that levels start to drift, and so needing like that extra booster to help keep those antibody levels high enough to make a difference should you get exposed to COVID, I think will be important. And I think it's more striking in our patients post-transplant that don't have immune systems working perfectly normally, but I think probably even the general population will likely need COVID boosters at some frequency that we still just need to determine.
Right. What I'm wondering, I had COVID in early January, and I was very fortunate to be able to get monoclonal antibodies the very next day after I turned positive. I had IVIG just a day or two before I turned positive, and I also had my third COVID shot maybe about a week before I turned positive. And despite getting COVID pneumonia, I did not too bad, knock on wood. And I had my antibodies checked recently, and I had not acquired any antibodies after my first 3 shots. But after my 4th shot, they do find I had a positive antibody response. Now, they're telling me they can't tell whether it was from the shot, from the natural COVID infection, or from the monoclonal antibodies. Do you know if there's any way that you can differentiate the antibody response?
There are tests that can try and help differentiate the different types of antibodies. So this is a question that often comes up, like, well, if I just get COVID and then that's my sort of natural immunity, if you will, versus the vaccine. And, the difference is, if you, we don't have this testing available, but if you really could test for every single antibody that your immune system made against actually seeing the COVID virus, that's, whatever piece is part of the COVID, virus that your immune system decided to make an antibody against, right? And it might not
necessarily have been what we call a neutralizing antibody, or one that actually helps fight the infection or helps the infection from getting back inside your lung cells again, versus the vaccine, which really focuses on that spike protein, which that's how the virus gets inside of your cells. So there's definitely differences in how the body makes antibodies against COVID versus what the vaccine is helping us with. But again, there's probably about 2 or 3 different labs around the country that do testing specifically to see if you've responded to the vaccine versus sort of a more diffuse panel that might indicate having had the natural virus itself. But it's possible that even being exposed to the virus itself, that you made an antibody against the spike protein very similar to what you did, what you would have seen to the to the vaccine. Sorry, did that make sense, or did I just confuse you more?
Yeah, no, absolutely makes sense. But I'm wondering, would, say for somebody such as myself or others in the same situation, would you recommend still getting the 5th shot, the 5th vaccine?
I would. You know, one of the things that I feel like is not covered, I mean, we see a lot of coverage on the news already about of COVID-19, but one of the things that I very rarely hear is, you know, coronavirus is, you know, non-COVID coronavirus is one of the most common causes of the common cold. And you can get it year after year after year. Your body, you know, helps you fight it off and make some antibodies, but you can see that same exact strain of the virus a year later, and you're going to get a cold again. So to me, it's not surprising that, you know, we get these nice spikes from having had the vaccine, but they're going to slowly decrease over time, and that you could potentially get COVID time and time again, just because of how our immune system responds to coronavirus different than some other viruses that we get long-term immunity from and not need those same boosters.
Right. And do you recommend any particular type of vaccine for the 5th one? Should you get the same as you've had before, a different one? I got Pfizer the first 3, and then I got Moderna for my 4th, and I had no reactions with the first 3. I had terrible reaction with the Moderna, but I did look at it as maybe a positive thing that maybe I was getting antibodies, and certainly ended up showing that I had some. But do you recommend the same, different, anyone in particular for the 5th?
You know, I think there will hopefully be more data to come about whether or not you should get a different type than you got initially, because maybe they're slightly different and can help sort of boost each other. I don't think there's enough data yet to say that I would tell any of my patients that they should definitely switch from one type to the other. I think whatever vaccine you can get and get it easily, then that's the one you should get.
Right.
Thank you so much.
If you had Moderna, then I would go ahead and get Moderna. I wouldn't turn it down just so you could go find the Pfizer. I would take whichever one you can get when you can get it.
Okay, thank you so much. You've been so helpful. I really appreciate it. Wonderful presentation. I just wanted to say hi to Jennifer, too. Hi, Jennifer.
Hi, Kathy. It's great to hear you. I heard some other familiar voices today, and I am so glad that you all were able to be a part of this. I really cannot thank Dr. Kitko and Whitney enough. I feel like this was such an amazing presentation. I know I definitely feel schooled today. So hopefully everyone got some information to discuss with your doctor, or some inspiration on, to keep persevering through this. But stay tuned. We have a Lunch and Learn on the third Wednesday of each month, and so there'll be some more Lunch and Learns coming up for us soon. And just thank you to everyone on the call today, our sponsors, our partners, and I wish everyone a wonderful day. Thank you so much.